I'm Dr. Neil Skolnik, and today we're going to talk about the 2023 American College of Cardiology, American Heart Association Guideline for the Management of Patients with Chronic Coronary Disease. Now, let me emphasize, this is about patients with stable, diagnosed coronary artery disease. This is not about managing acute coronary syndrome, MI, or post-MI management. That is going to be done by our cardiology colleagues. Patients with chronic coronary disease represent a large group of people. We see over 20 million people in the United States. There's a lot in this guideline, so I'm going to select the parts of the guideline that are most important for us in primary care. First, and new in this guideline, is that routine testing for ischemia, things like stress testing, is not recommended except when there's a change in symptoms or functional status. This is because 3 trials, the COURAGE trial, the ISCHEMIA trial, and the BARI 2D trial, showed that in patients with stable coronary disease, there's no benefit of revascularization versus optimal medical therapy. So when we see patients with coronary disease, we want to make sure that their symptoms are stable and that their medical therapy is optimized. So now, let's talk about what that means. First, nutrition and physical activity. We often skip over this, but it is critically important. Mediterranean-style dietary plans can lead to a 65% reduction in composite cardiovascular outcomes like cardiac death and recurrent MI. Higher quality carbohydrate intake, which means cutting down on highly processed carbohydrates, leads to lower cardiovascular morbidity and mortality, as does lower saturated fat intake. Now, what doesn't work when it comes to diet is fish oils, particularly omega-3 fatty acids, as well as antioxidants like vitamin C and E. Don't forget physical activity. Goal being 150 to 300 minutes a week of moderate to vigorous aerobic activity, but remember, small amounts of activity are also helpful. All of this leads to improved functional capacity, quality of life, and a decrease in hospital admissions and mortality. Add resistance training, that is strength training exercises, 2 or more days a week, and try to decrease the amount of time spent in sedentary activities. Mental health, of course, is also important. Depression, anxiety diminishes quality of life and leads to worse cardiovascular outcomes. And obviously, if someone is smoking, do your best to get them to quit. Let's now talk about lipid management. High-intensity statin therapy is recommended with a goal of 50% or more reduction in LDL cholesterol. If someone is at very high risk, the goal is an LDL less than 70. If a person is not to go on a statin, then ezetimibe can be added. If adding ezetimibe doesn't do the trick to get LDL less than 70, then we can consider adding a PCSK9. If further lowering is needed after that, then the newer agents, bempedoic acid and inclisiran, can be considered. If on maximally tolerated statin therapy, the fasting triglyceride level is repeatedly between 150 and 499 milligrams per deciliter, then based on the REDUCE-IT trial, icosapent ethyl may be considered. Remember, icosapent ethyl is different than over-the-counter fish oil. Hypertension management is, of course, important. Here, the blood pressure goal is less than 130/80. Now, regarding some specific medications, beta blockers, the old staple for coronary disease, does not have a benefit in patients who have not had a previous MI or have a left ventricular ejection fraction less than 50%. And if someone is more than a year since their MI without other indications for beta blocker, then a beta blocker might not be particularly helpful. ACE inhibitors or ARBs have a class 1 recommendation for patients with chronic coronary disease and hypertension or diabetes, left ventricular ejection fraction less than or equal to 40%, or chronic kidney disease, and a class 2B recommendation in the absence of those indications. So ACEs or ARBs are a good initial choice for treatment of hypertension in people with coronary disease. For people with diabetes and chronic coronary disease, remember GLP-1 receptor agonists and SGLT2 inhibitors reduce the risk of MACE. Weight management is important. Excess weight accelerates atherosclerotic formation. Lots of options exist. Of course, discuss lifestyle management, diet, and exercise. A GLP-1 receptor agonist can also be considered, and the guidelines say it's reasonable to choose semaglutide over liraglutide because of its greater efficacy. Recognize that the guidelines were released before the top-line results of the SELECT trial were announced, which showed that semaglutide decreased MACE in people with chronic coronary disease and obesity. Remember, bariatric surgery can also be considered where appropriate. The guidelines cover a lot of details about antiplatelet therapy, sticking to those with coronary disease but without AFib or another reason for anticoagulation. People with coronary disease should be on a low-dose aspirin, 81 milligrams per day. If someone is post-MI or post-stent, there are lots of nuances with regard to antiplatelet therapy, regarding length of dual antiplatelet therapy, even the place of low-dose DOAC, direct oral anticoagulants. These decisions will be made by our cardiology colleagues. Colchicine, the old staple for gout, which acts as an anti-inflammatory, is now in the guidelines with a class 2B recommendation as a may be considered to reduce recurrent ASCVD events. And don't forget immunizations, influenza, COVID, and pneumococcal vaccines. And this is not trivial. There's actually an association that's been found between respiratory infections and MIs. And in fact, there's now good evidence that influenza vaccine leads to a lower risk of MI, cardiovascular death, MACE, and all-cause death in patients with chronic coronary disease or heart failure. For symptoms, beta blockers, calcium channel blockers, and long-acting nitrates are recommended for symptom relief, and ranolazine is recommended in patients who remain symptomatic on those medications. Those patients should be seeing a cardiologist to decide whether they need further evaluation for their ischemic disease. We're not going to talk today about decisions regarding further evaluation, but suffice it to say, this is where clinical judgment comes in about when to test or refer if a patient has a significant change in either function or symptoms. So this is a lot of information. Let's summarize it. In summary, routine stress testing in patients with stable coronary disease is no longer recommended. Diet and exercise are critical, underappreciated, and make a big difference. LDL cholesterol goal is less than 70, and don't be afraid to add a medicine to the statins. We're used to using statins. Don't be afraid to add a medication. Consider, in addition to statins, consider icosapent ethyl for triglycerides over 150. Blood pressure target is less than 130 over 80 with a preference for an ACE or an ARB as a part of the regimen. Don't forget the importance of weight management. The correct cardiovascular event reducing medicine and someone has diabetes is important to remember, and that should be a GLP-1 or an SGLT2. And don't forget about immunizations and an aspirin a day. This is important information for something that's common. This is bread and butter medicine, and it is a lot of it. Of course, I'm interested in any thoughts that you have. Please leave them in the comments section below. I'm Neil Skolnik, and this is Medscape.